We've got a fascinating privilege today to speak to two great leaders from Northwell Health. Northwell Health is the largest health system in New York. I think it has now, I heard yesterday, somewhere between almost 74,000 employees or so forth, 23, 24 hospitals. It's done this magnificent job of being a great system and a safety net system, doing both throughout the state of New York. It's brilliantly led by Mike Dowling, who we've had the privilege of having on the Becker's Healthcare Advisory Board for a long time. Just a brilliant leader. Northwell's been extraordinary in developing a lot of different growth strategies, including a robotic surgery program. We're going to talk a lot today about growth, about how they think about growth and perspectives on it. I'm joined today by Frank Cascio and Aaron McCoskey. I'll ask them to take a second to introduce themselves, tell us a little bit about what you're doing. Frank, let me ask you to start with introducing yourself, and then Aaron.
Sure. First off, Scott, thank you very much for inviting Northwell to participate in this event. So far, it's been a fantastically run show. My name is Frank Cascio. I am the AVP of Program Management within Northwell Health. I have a specific focus around administering our system robotics program throughout the network. Another unique advantage that we do have is we are also Western Region ambulatory resources. So that gives us the unique perspective of both understanding the perioperative process, but then also appreciating how patients get to the perioperative space through the ambulatory development. So happy to be here today, and thank you for inviting us.
Thank you. And Aaron, can you take a moment and introduce yourself?
Yeah, and just want to echo what Frank mentioned. Thank you for the opportunity to be here and tell a little bit about our program. So I'm the clinical director of assistive robotics, and also, as Frank mentioned, have a bit of a dual role in operations of our Western Region ambulatory program. I come from a clinical background, physician assistant in cardiothoracic surgery. So it's a unique advantage to validate our program from a clinical side and able to now branch out and support service lines outside of cardiothoracic surgery. So happy to share some of our insight today.
Thank you very much. So Northwell has grown from a merger, I guess now, how long ago was the merger with Long Island Jewish?
2008.
2008, into this very successful, very innovative system. Frank, when you talk about innovation in people management and leadership, what does innovation look like at Northwell? Talk a bit about what you see there.
Well, I think it starts with your executive team, your C-suite. Early on, I think our executive team within Northwell is willing to make investments in cutting-edge technology. And the charge that we specifically were given in 2017 when we formed our committee was demonstrate superior quality outcomes, and we'll continue to invest within the program. So back in 2016, there was not much intelligence from a data perspective around our program as a whole. And being a data geek myself, I think that's why I was kind of assigned this position within Northwell of really understanding the impact and the benefit of robotic surgery for our patients. And over the years, we've really been able to demonstrate a superior quality outcome when robotic-assisted surgery is performed within our health system for our patients. So ultimately, our initial charge of demonstrate better outcomes, and we'll continue to invest in the program. Our executive team gave that to us, and we've been able to deliver on that, which is why we've continued to invest in the program. And all of this would never have been able to be accomplished not for our partnership with Intuitive Surgical. In 2017, we sat down and we kind of understood what the imperatives were for our organization. And we entered into a fundamental shift from a capital outlay program to a flexible acquisition model, which really enabled us to rapidly grow, safely adopt the modality due to exposure for our surgeons. And the rest is really history. So from there, we've taken the ability to benchmark our program not only internally, nationally, but also against other modalities. And I think that has given us the confidence to really grow our program quite dynamically over the years.
And Frank, take a second on this. In making this sort of acceleration of digitally assisted or robotic surgery, talk about a couple different things. Take a moment and how many surgical robots you have now, or how many robots you have in the system. You've got 23 hospitals. And talk about the clinicians and their perspectives, newer physicians, older physicians, in adopting to robotic surgery.
Well, the evolution of our program has been tremendous. We started with 12 robots in 2017. We now, at the end of this year, will have 83 placed robotic systems. That's a tremendous amount of growth, and it isn't done just based off of feeling. It's done based off of data. And I'm happy to say that we've been able to collect enough robust data to make data-driven decisions. And it was a journey to get here. When we first began, we had a number of hospitals that were all doing robotic surgery, but each one coded robotic surgery a little bit different. Some did under ICD-10, some did under CPT, some were CDM codes for supplies. So just getting the intelligence to create that reservoir that we could then really mine to understand the evolution of our program was, incredibly important. And what you'll see on the screen here is just our overall adoption. I think collectively with Intuitive, one of the things that we wanted to do was reduce open surgery. And I think as healthcare leaders, we can all agree there. We want to reduce open surgery and perform and provide a minimally invasive solution. But beyond that, we've been able to understand via the data that it isn't just a minimally invasive solution, it's a robotic-assisted solution for our patients. And quite frankly, it's become the standard of care. And I use myself as a barometer. If I had to have a surgery, what would I want to have? And quite honestly, you'll see within the data, it's going to be robot-assisted surgery.
Thank you. And Aaron, you do a lot of work on the data side of this. When you look at financial challenges, clinical outcomes, obviously a huge decision to make this kind of investment, 83 robots, I think, currently. I mean, that's a large number, and I know the program's going great. What data helps validate that decision, makes that make sense to do that versus investing further in lap towers or other kinds of things? And would love to take a moment on where is robotic surgery being done the most? What specialties?
So what you'll see in a couple of slides here is this is our value slide and how we validate our program. As Frank mentioned, we've been able to benchmark our robotics data and look at what quality means to us. And across the board, this is Northwell data, and this is all inpatient soft tissue discharges, non-emergent. And so across the board, we stopped comparing to open. We've been starting to compare to laparoscopic, but lowest length of stay, readmissions, complications, and transfusions. And so this is why we do and are really interested in robotics and excited about our program. So it's the quality and why we do, why we really promote robotics as a modality of choice.
Thank you. And then, Frank, as you saw this evolve, the difference in investing, choosing, do we buy more lap towers? Do we do this? Where is it being used the most? What specialties? Help us through that a little bit.
Well, through our discussions with Intuitive, as we came to the point we want to renegotiate and re-enter into the next evolution of our partnership, we really took some time to not only understand the quality, because that's very clear, you can see it on the screen, and if you're doing the math, this is over close to 12,000 patient days saved compared to laparoscopic surgery. But really understanding the perioperative footprint that we have, not just from a robotic standpoint, but also from a laparoscopic standpoint. And on the previous slide, you saw our non-emergent growth, right? So the simple calculation was trying to come up with the number to get us to the 83 was we're projecting or anticipating our modeled growth to be around 30% of our inpatient surgical discharge volume non-emergent. Doesn't it make sense to also have a footprint that matches that obvious need? So what we did was we did an inventory of all of our ORs, backed out which ORs had robotic systems already placed within them, backed out any orthopedic, neurosurgery, vascular, plastic ORs that were dedicated to them, and came up with a number of what we thought was reasonable. So our growth was projecting to be 30%. We wanted to have a footprint of systems that matched that growth. So lo and behold, 30% of our ORs are now going to be outfitted with robotic-assisted technology, which brings us to that 83 numbers. And really what that was about was getting the exposure to our surgeons that were coming in and trying to gain access to the technology, but we're having constraints due to inability to get into the block time. And one of the other things that I think was unique about Northwell is, we formed a credentials committee very early on. And in the beginning or the onset of that program and creating that committee structure, we were credentialing anywhere between 1 to 2 every other month initial applicants. More recently, that growth has been tremendous. Anywhere between 9 to 15 initial applicants are requesting initial privileges to perform robot-assisted surgery. So although our fleet size is great today, we knew we needed to do something a little bit different. So really analyzing the data and being able to mine it yourselves enabled us to understand where we think we're going with this program, and we needed to right-size our fleet to match the demand.
And To answer your question on within what service lines, where we see the most procedures being done, over the last 2 years, our most robust growth has been through low acuity general surgery, your cholecystectomy and your hernias, and really ventral hernia as well, from a robotic approach, has really turned into an ambulatory procedure for us. And as well as bariatrics too. That was our second highest growth area. And important to us, and if we go back a slide, outside of the quality that we measure, we also to comment on the CMI. So we've noticed since 2017, our CMI, average CMI of robotic cases done has continued to increase. It was up to 2.21 this year.
Yep.
Then it's the modality of choice for all of our malignant surgery. Because the denominator's gotten so large, on that previous slide, the percent cancer looked like it was going down, but that's just due to the denominator. When you normalize the data, the robotic approach is our modality of choice for all of our malignant cases.
How important is it, this management of communication? You get this great data analytics, it really tells a story about lower length of stays, lower days in the hospital, outcomes and so forth, and ultimately, how important is that constant communication between your teams and physicians and leaders and care teams and so forth? How important is that as part of this?
Well, I think that we kind of highlighted the investment that we made into innovative technology earlier on, and it came from our C-suite. But that wasn't the only solution that we needed to get beyond. First off, we needed to address some of the financial concerns around acquiring a $2 million piece of equipment, and that was through the flexible acquisition model. But beyond that, we knew we needed to also govern the program appropriately. And with the breadth of our system and the number of hospitals that we have, we needed to have local leadership participating in our central robotics committee to disseminate that information, be those arbiters on our credentials committee to hold accountable your surgeons that you're asking to be proctored 3 times, or that you're requiring some form of remediation, not punitive, but remediation around, improving overall operative times or anything of that or in the quality side. So I think that's incredibly important. You need to have a central committee that is that consistent glue piece that brings the entire program together. But you also need to have that local participation to help drive and advance the initiatives that from a central standpoint, we find it as an imperative to really continue to evolve and advance the program.
And most large systems would say, particularly in today's world, we're going to consolidate this service or that service or this expensive equipment around these 3 campuses. You folks made a very different choice, that you basically said the future is robotics. We're going to have robots at every single hospital. We're going to have surgical robots at every single hospital. We might not have 10 at every hospital, but at every hospital. What drove that choice, and what is the generation of residents coming out think in terms of robotic surgery versus open surgery? What are you seeing there? And talk about that choice to put a robot every place versus centralizing.
Right. I think a lot of it's a testament to the low acuity general surgery growth. Every hospital does hernia cholecystectomies. It's preferred approach for our surgeons. You could see within our credentialing process of 9 to 12 initial applicants that are requesting privileges. The other component, we recently placed one at a small community hospital in the North Shore of Long Island, specifically around recruitment. The executive director, to remain competitive within that market, appreciated that some of the patients within her geographic area were leaving and bypassing her hospital to go to receive robotic care at a competing institution. So it was increasingly difficult for her to attract and retain surgeon talent to provide the patients that are demanding this type of care within her facility. So what we've seen is every single hospital outside of one, which is an orthopedic hospital, does now have a Da Vinci system.
And we really appreciate, as Frank mentioned, with the credentialing piece, is that we were credentialing a higher volume of robotic surgeons each month. And to stay proactive in our approach with our program, we looked at what are the residents and fellows being trained on in their training. So we see that almost the majority of all of our residents and fellowships coming out of training have a certificate of competency on the robotic technology. So that's become part of our credentialing process too, in standardized form. But we expect that this will continue and want to allow them to have access once they graduate, because it is so important to continue those touches on the system, and there's not a lag. So if we anticipate residents or fellows are coming out, we're hiring them, or they're going to join a certain site, we need to make sure that they have access to the system so that their skill set will be maintained.
Talk for a moment about how important that is. If somebody doesn't do a certain amount of surgeries in a certain period of time, they don't get very good at this. And the adaptability of residents coming out versus how much interest is there from senior general surgeons who've been doing surgery for 30 years. They're learning the robotics. What do you see out there, some of that, and how much does somebody have to do? And your point is well taken. You need to have access for somebody to stay current on their skills. So if they can't do it regularly all the time, then it's occur. But talk about some of those demographics and what you're saying.
Yeah, so we still do see a lot of surgeons transitioning from traditional open or laparoscopic to robotic approach, as well as the residents coming out of training. And so we do take a collaborative evaluation of every surgeon with Intuitive to who is the right surgeon to be a robotic surgeon, because it's multifactorial. Do they have the anticipated volume is a really important point. Due to that need to continue to perform procedures and not lag on their skill set, because we never want to just train somebody in robotics and then them to be slower, less efficient, worse outcomes than their traditional approach. So we need to take that collaborative approach to who is the right surgeon to be a robotic surgeon and set them up for success.
How many cases does somebody have to do to start to get confident, to start to get competent with robotic surgery?
We found within our data that typically after the 20th procedure, and obviously it's procedure specific as well, but traditionally 20 procedures, high exposure early on, begins to normalize the operative times and the outcomes to what we would expect, or what the surgeon had expected to do laparoscopically. So it's really about, one, selecting the appropriate surgeon, two, it's partnering with Intuitive to hone the skill sets, and then three, it's providing them the access to really get the exposure to hit that 20th case so we can begin to appreciate the efficiency and value add that a true robotic surgery program has.
And Aaron, take a moment on this issue, both the constant evolution towards digitally assisted surgery versus analog or open surgery. What are some of the trends you're watching? What do you see? How quickly is it moving towards everything that can be done digitally assisted is done digitally assisted? And what's the challenges in developing care teams around this? Nursing teams, care teams, clinical teams around robotics, and how does that look?
Yeah, I think that, there's a lot of buzzwords right now in terms of AI, digital OR, and, it's the right product for your facility. And so at the end of, or all through last year, when we renegotiated our contract with Intuitive, and the more that Frank and I learned about Intuitive Hub and telepresence, the more use cases that we came up with for this. And so that's where we see value in this, and how it can not just affect and help the surgeon produce better results and outcomes, but everyone in the team, as well as some creative ideas that we had. So of course, the surgeon, in terms of capturing video and picture and replay, how that can improve their skill set, but also building referral relationships. So calling in the referring provider during a case and showing them actually the tumor that they referred to them, and say, this is patient so-and-so just about to complete the resection, and just want to let you know everything's going well, as well as intraoperative consultations. From a clinical side, I appreciate how long it takes to request an intraoperative consult. That can be like not even knowing who's still in house. Do they have to change into scrubs and come back to the OR? It can put like over a 30-minute delay on your OR. And so being able to remotely ask opinion of a different service line or a different provider is a huge value add, as well as Frank mentioned our proctoring process, to be able to align a experienced surgeon with a more junior surgeon for proctoring or preceptorship are some of the ones we saw for this surgeon. But outside of that, our care teams. And by that I mean our bedside assistants, which at Northwell we feel that PAs, NPs, or RNFAs really support the procedure best, as well as the RNs and techs. The ability to use the hub for care team training, case observations, showing them what ideal room setup looks like, and back table preference cards, instrumentation for certain surgeons to really increase that efficiency of how they're onboarded. Residents and fellows, case observations, we have 16 hospitals, and if a resident or fellow is way out on Long Island, but they know that a really best-in-class thoracic case is being performed in the city, ability to watch that case remotely and get experience. They can also continue to link everything with their MyIntuitive app. And then within our graduate programs, our RN, FA, RN, NP, and PA schools, how can we integrate with them early and drive that interest so that way we're preparing them best when they come out of training? Same with our medical school. Dr. Battinelli, our Dean of Hofstra Medical School, he has created a second-year elective for our medical students where they'll start to have some exposure to robotics because we feel the most exposure early on will result in better trained surgeons. So how can we change those models and give that experience earlier?
Yeah, let me just try and characterize some of those into lessons for the audience in terms of proctoring, care teams, training and a bias towards NPs and PAs being involved, learning early. You're using different modalities to teach. So if you're doing a case far away from somebody they can watch in on it, particularly as they're learning and so forth. Any other pieces of advice you'd give people from the clinical side of improving their robotic surgery program?
I would say, find somebody that's a leader within that space and has strong interest because if you can drive excitement around the program, they'll start to feel part of it and enjoy what they're doing. And so I think that, and if you're considering placing a system, if there's opportunity to take that system early and just not turn it on, use that for training and get the team trained and exposed and get the touches on that. And if we can really train all providers and not just a robotic team or a team, that way that we can help the surgeons move past that 7 a.m. to 3 p.m. That's the A team. And do we have to switch to open or laparoscopic later in the day because we don't have the team to support that? So I think that's where we need to go with care teams.
You've ultimately, Frank, made a transformational and directional change to go hardcore and accelerate in this direction of robotic digitally assisted surgery. You compete in one of the most competitive markets in the world. You're in New York City as well as the surrounding areas. You compete with Columbia, Cornell, New York Presbyterian, and so forth. Out of leadership, and you also do this magnificent job, the largest system in the state, serving the most patients in the state, so you both have to serve poor communities, wealth communities, everybody. I mean, and Northwell does a magnificent job of it. How did you get leadership, or how did leadership decide to make this kind of transformational effort to become a leader in digital surgery? I think you're the second largest utilizer of Da Vinci robots in the country. How did you guys make this transformational change and investment? Because it's not cheap. How did you decide to do it? I mean, I guess the numbers will show it's not any more expensive than open surgery, particularly if you get length of stay damage down. But how do you make this kind of transformational decision and investment?
I think it starts, again, from the C-suite. The C-suite recognized and appreciated the surgeons were saying that this had a superior outcome for their patients. Being able to measure that has provided us with the confidence to really move forward and invest in the program. And I think we've selected a very unique partner in Intuitive. I think that, as Aaron had mentioned and you had mentioned as well, AI is a buzzword that we've been hearing consistently throughout this past few days. I think it's a bit of a dangerous word, though. I could perform AI in Excel, linear regression. So partnering with the right, and that's the other topic we've heard a lot about, right? Partnership. Selecting the right partner. What we've seen with Hub, that is true AI.
But who at Intuitive? Is it Mike Dowling? Is it clinical leadership? Is it surgeon leadership? Because this is obviously a major investment versus other capital projects. I mean, by the time you're done, whether you bought 23 robots here or bought them in a robotics and orthopedic surgery from a different, it's a big commitment to go this direction. By the time you're done, this is a big part of the capital investment. You do the flex program, do those kinds, but it's still a serious commitment to going in this direction. Who at the top of the system decides, or who's involved in that decision that we're going to start this program and then we're going to accelerate and double down on it because here's the outcomes, here's what's going on? Who's involved in that discussion? Because I can't imagine it's done at a local level. I mean, it's got to be a system decision when you're investing this much money.
So our chief medical officer, Dr. David Battinelli, was involved in the initial conversations back in 2017. He's now taken on, as Aaron had highlighted, to become the dean of the medical school. Our executive sponsor now is Dr. Jill Kalman, our chief medical officer. So I think it becomes clear that this is where we're headed, right? I think this is laparoscopy 2.0. I think we've been early adopters and kind of believing in the program, and a lot of that's through surgeon demand, understanding where the pain points are, and then working with Intuitive to really understand the challenges that we've had. How do we overcome them? And if the people in this room are anything like we were, in 2016, the program was met with a lot of cynicism. It takes too long, it's too expensive, no outcome benefit. I think if you can use data to kind of overcome some of those misconceptions, because that's clearly what they are, I think it becomes a very clear strategic decision to move forward in a modality that is becoming a standard of care for patients.
So Dr. Battinelli, who I know, brilliant person, he becomes the original pioneer or driver of this. How quickly did it then accelerate? 2017 is when you really started with robotic surgery, digitally assisted surgery. Did you start with one or two? What did you start with? And then how quickly did it evolve to now you're going to have 84?
So we had started with 12 robots in 2017. That was the number that we had. For anybody that's doing the math, it's a incremental 71 systems that we brought into our health system. That could be close to $150 million of capital that nobody has. So really understanding that and partnering to develop a flexible acquisition model has enabled us to grow at that point.
How quickly did those 12 systems start to get utilized, start to get busy? Because obviously, if they're not used, then nobody at the systems is going to say we need more of these.
Right.
How long did it take for them to start getting used? What was that like? What was the ramp up?
I mean, the growth has been tremendous. In 2017, we did 737 outpatient procedures. This past year, we closed out at around 5,000 outpatient procedures. So that low acuity growth has really taken off quite tremendously. So we have basically maximized every single system that we have now, and this provides unfettered access. And the beauty of the flexible acquisition model is if you don't use it, you don't pay for it.
And so how many do you project to do in 2023, just roughly? You did 5,000 outpatient surgeries on it last year. What do you project this year?
I'd anticipate we're going to probably end the year about 15,000 Da Vinci surgery procedures.
And how important is it, do patients might not understand they're looking for a Da Vinci robot, but they're certainly looking for minimally invasive surgery. And people are educated enough to know I'd rather have surgery where my length of stay is going to be shorter versus longer. How much patient pushes there on that as well?
I think it's quite dramatic, the evolution. In 2017, we created a website that was devoted to our program. And part of that, we had a ability for a patient to engage with our team to kind of be consulted for a robotic procedure. And in 2016 or 2017, we were receiving messages around, does the robot do the procedure? I think we've become savvy enough, and it's become a patient demand that they want robot-assisted surgery. I would want it. When I referred my mother who needed surgery, I referred to a robotic surgeon.
Did it go okay?
Went great.
Good.
Yeah.
Good. No, it's actually phenomenal. It's actually amazing to watch the exponential growth of it. I remember years ago first talking about open surgery versus robotic-assisted surgery, and exactly those questions of physicians being scared, is it going to take over my job, or a patient, is it really a robot doing the surgery versus assisted,
Right.
and so forth. I mean, it's fascinating growth and acceleration in it. Aaron, talk about sort of as you look at this, as you look at what you're most excited about here, give us some of your final thoughts on where you see this going and what you see.
So I see, again, I think, look back at where the surgeons are coming from, and everyone that is deciding in medical school, I want to be a surgeon. I think that if it's in the soft tissue space, it's really heavily integrated within robotics. And so if we want to continue to offer that access to the surgeons, we need to anticipate that. And some ongoing analysis that we're doing is, why are we just increasing our robotic fleet size but not looking at anything else? So what we're doing is looking at our laparoscopic fleet, and we need to right size that, because our real estate is not getting any larger. And so if we know we're decreasing our laparoscopic volume while increasing our robotic volume, we need to take analysis of that too, to be more efficient and really understand where the dollars are being spent in the ORs. So that's something we're excited about. And I would just recommend, really before you make a true opinion on is it truly beneficial, to really immerse yourself in the technology to truly understand it, and then look at your own data as well and really understand that, because then you can truly understand with true data what the results are. And I think we're all here for the patient, and we want them to receive the best care. They don't want to be in the hospital. They want to go home. They want to get back to their normal functioning. And how can we do that best for our patients?
When you talk about, you've mentioned the capital expenditure of buying 80-plus robots. You've talked about this concept that it's not necessarily all an expense, because over time, your capital expenditures will shift. I mean, because you won't be buying certain other things, and ultimately, hopefully, you'll end up with much lower lengths of stay and much more satisfied patient population. Talk about some of those cost-benefit assessments that, and that you guys talk about and think about in terms of shifting spend.
Yeah, so I mean, I think that's just the overall intelligence on the perioperative space. We did an inventory on our laparoscopic tower fleet. It took 3 months to acquire it. And what we've realized, we have essentially the same number of lap towers as we do ORs. But if you saw on the screen before, robotic assisted surgery accounts for 25% of our overall soft tissue surgery. So it's not just, and I think this new negotiation we performed with Intuitive exposed Aaron and I to, not just obviously honing our data sets around robotic surgery, but, what can we do to right-size our entire perioperative space? Aaron mentioned before that OR sizes aren't increasing. So how do we become more efficient? And it's one, acquiring your own data to make your own intelligent decisions. But it's also then partnering with the MACA team, which is the Intuitive data team, to really understand how can I improve efficiencies from the robotic side.
But when you're in a place like New York City, and it's really true every place, if you're in a smaller community, a more rural community, you're probably not building more ORs today. In New York City, there's obviously, you can't even get a hotel room, let alone a new OR and stuff like that. And so there's this real premium on using your ORs right and using them efficiently and using the data to drive that.
Yeah. I also think it's in 2017 when we placed the robots, and many of you probably have the same story, we selected the largest ORs that weren't being used for neuro, spine, ortho. I think moving beyond that misconception that it needs to be in a 500 square foot OR is something that we all need to start appreciating. And our medical director of our program, the square footage of the OR that he operates out of is, I think, less than 270 square feet. So, when placing 83 robots, we're not placing them, we can't place them in the largest ORs.
Does that medical director need to do more cases to get a bigger OR? No, I'm just kidding.
Yeah.
But I mean, it must be fascinating. So, Frank, you guys have really driven this program. It's the second largest in the country, I think, in terms of robotic surgery. And you said 24% of soft tissue right now is being done with robotically. What's your prediction on that? I mean, you might have said that already, but what does that look like a few years from now?
I'd expect it to continue to grow. We have 133% growth from beginning to really govern the program in 2017. That's phenomenal growth. And what we see is our overall, and when you look at the trends of growth that we've received, I think 30% this year of soft tissue surgery, I think it's very realistic for us to get there.
What's our percentage of surgeries? I mean, there's got to be some percentage of surgeries that at least at this point you can't do without doing them open or totally invasive. What percentage of surgeries does your, and there might be certain age reasons or other reasons why you use one modality versus another, but is there, I mean, there must be like Dr. Bettinelli, Jill, Dr. Kalman, they must think about, ultimately the universe. Is it 80% of open surgeries that soft tissue surgeries that ultimately will be robotic? What's the universe look like? Do people, you guys talk about those numbers?
I think the story's still out on what that's going to look like. What we can use is our historic data to understand what the growth is. Again, 133% growth since program inception.
But we literally went from 750 surgeries the first year to 5,000 last year to 7,000 or 8,000 this year, or a lot more.
Yeah.
Or a lot more, I guess. What'd you say was the number that you expect this year?
Close to 15,000.
15,000, right. So it's a huge growth. It's amazing. And so any final takeaways or pieces of advice that you give to other health system leaders? I'll ask both of you just real quick for a piece of advice.
I think that's our program has really been defined by a couple of pillars, right? It's one, how do you acquire the technology in a way that makes sense for your organization? It's really then establishing a governance structure within your health system to really disseminate the information, the policies that have been established from a central standpoint. The importance of standardization, I think that is key, and that's at the core of everything that we do. We want care delivered at Lenox Hill to be the same at Peconic Bay out east on Long Island. It's establishing your dissemination channels. Who are the local leaders that are going to bring back the policies, the procedures, the credentialing standards back to the local site, and it's data transparency. I think we've had a lot of success with going out and meeting with non-robotic surgeons when we are able to demonstrate that for a colorectal procedure, we're removing 3.2 days length of stay for a robotic procedure. I think that alongside having a core team that really oversees the program, governs it effectively in partnership with Intuitive, helps to drive that type of information. So it's develop your acquisition model, establish a governance structure, standardize the program, disseminate the information, and lead with data transparency.
Thank you very, very much. I'm going to ask you just to run off those 5 suggestions again, just very quickly for anybody that wants to take notes.
Yep, it's develop your acquisition model, partner with Intuitive. It's govern your program, establish a governance structure within your health system, standardize as much as possible, disseminate the information at a local level by involving clinical leaders at individual institutions to participate in the system governance. And lastly, it's lead through data transparency.
Thank you. Aaron, any final thoughts you wanted to share too?
I think the systemic governance can't be said enough, and that, within our program, 1 core team and 16 hospitals. We have leaders that we think they're the right surgeon leaders at each site, and the committee guidelines and the standardization that we preach, we rely on them to govern their own site. And we have an open line of communication, lots of transparency with those leaders. And so that way everyone's speaking the same language, everyone's interested in the same goals and vision, and tons of communication so we can work on things together. That's how we drive the excitement around the program. And, it goes hand in hand with growth. I think that it's changing how we onboard our providers. We think of robotic surgery, initially you think of just the surgeon, but let's also think about the care teams that are needed to support the program. So what is our current onboarding model, and does it need to change given the responsibility of those providers? And how can we get them trained? Because another buzzword in robotic surgery is your 24/7 access. That's only going to, if you ask a surgeon, they'll operate any time of the day, night, or weekend. But they can't and are only limited by those care team providers. So how can we change our onboarding and get competency within our staff to support that growth as well?
Thank you. I mean, in a daunting economic time, it's an amazing transformative investment that Northwell has made in this area of care. I want to thank Frank and Aaron for taking time with us today to talk about this. It's really remarkable, sort of like investment and transformation. Thank you very much for joining us. Thank you.
Thank you.
Appreciate it.
Thank you, guys. Thank you, folks, very, very much.